Hey everyone, welcome back to the channel. Today we're diving into a topic that's controversial, misunderstood, and let's be honest, frequently misdiagnosed: fibromyalgia. Before we begin, this video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check information with trusted sources. So what exactly is it? Fibromyalgia is a chronic pain syndrome that affects about 2 to 4% of the population, mostly women. It's known for widespread pain, constant fatigue, poor sleep, and that classic fibro fog where your brain feels like it's wading through molasses. But here's the twist. It's not caused by inflammation or joint damage. It's actually a problem with how your nervous system processes pain. Think of it like your brain and spinal cord turning the volume way up on normal sensations. That's called central sensitization. Now, how do we diagnose it? Forget the old tender point exam. These days we use two tools: the Widespread Pain Index, or WPI, and the Symptom Severity Scale, or SSS. WPI looks at 19 areas across your body: shoulders, arms, back, legs, you name it. 1 point for each painful area. Max score 19. Then there's the SSS. It measures things like fatigue, unrefreshing sleep, and cognitive fog, on a scale from 0 to 3. You can also score extra points for things like headaches, abdominal pain, or depression. Altogether, it adds up to a maximum of 12 points. So when do we actually say, yes, this is fibromyalgia? If your WPI is 7 or more and your SSS is at least 5, or your WPI is 4 to 6 but your SSS is 9 or higher, and these symptoms have lasted at least 3 months with no better explanation, then yes, fibromyalgia is likely. But here's the thing, this isn't just a diagnosis of exclusion, it should be a diagnosis of inclusion, meaning we don't stop looking just because labs are normal. And that's where things get tricky. Because fibromyalgia often becomes a fallback diagnosis when nothing else shows up. Negative blood work, normal imaging, vague symptoms, boom, fibromyalgia. But we miss real diseases this way. There are several conditions that mimic fibromyalgia, especially early on, and don't show up on routine labs, like non-radiographic axial spondyloarthritis. These patients often have chronic low back pain, morning stiffness, and fatigue. But x-rays, clean, blood work, totally normal. You need an MRI to see inflammation in the sacroiliac joints. Or psoriatic arthritis. It can affect the joints, tendons, even the spine, and it's often seronegative. Psoriasis? It might be hiding in the scalp, nails, or gluteal cleft. Easy to miss. And don't forget early or seronegative rheumatoid arthritis. If you're not doing a thorough physical exam, you might mistake it for fibromyalgia. Bottom line, just because labs are normal doesn't mean it's fibromyalgia. So what do we do when the diagnosis is correct? Treatment starts with non-drug strategies. The top 3: exercise, especially low-impact aerobic activity, cognitive behavioral therapy to help reframe the pain experience, and sleep hygiene because poor sleep amplifies everything. Medications? They're secondary. SNRIs like duloxetine, TCAs like amitriptyline, or gabapentinoids like pregabalin can help. But opioids? Absolutely not. They tend to make things worse over time. So here's the takeaway. Yes, fibromyalgia is real. Yes, it can be debilitating. But we have to be careful not to make it the default when we don't know what else is going on. If you're a clinician, stay curious, dig deeper. And if you're a patient, know that you deserve a diagnosis that fits, not just one that's convenient.